Good morning, all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, I would like to introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. for you to join in. No late attendees will be entertained thereafter, and each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These rules are to improve and maintain the standards of the CPD programs conducted by the SHRI. You can ask questions at the end of the webinar, and if you have any question, please type it in the chat function. And if you have very specific questions about your situation, please email us on office3@gmail.com. So today our topic is management of urological emergencies. I would like to introduce our guest speaker, Dr.B.Balagobi, Senior Lecturer, Department of Surgery, Faculty of Medicine, University of Jaffna, and Honorary Consultant Urologist, Teaching Hospital, Jaffna. Over to you, sir.
Good morning and welcome to the webinar series. First of all, I have to tell there's a lightning issue here in the hospital, so there may be a power failure in between. That's happened. I will join within a few minutes. So that's with that announcement. Welcome to the webinar series. Today, I'm going to talk about a common issue that you will see in surgical wards, or maybe in medical wards as well, and also in the primary care delivery system. So I'm Dr. Balagobi. I'm a urological surgeon attached to the University Surgical Unit. So in the urology, we deal with the kidneys, ureter system, external genital system in both male and female. Mainly the males with the scrotum and the penis. Now, there are a lot of emergency. I have just going to cover the common issues. That's usually the acute scrotum, the urosepsis, and obstructed kidney with AKI, paraphimosis, and the clot retention. And I will touch upon Fournier's gangrene as well. There are a few rare emergencies like penile fracture, priapism, but they are not so common, so I'm not going to deal because those are usually encountered by the specialists. Now, this is a very common scenario, acute retention, and if you have seen the patient with acute retention, you know how painful this is, and you know, every day you will see 2-3 patients if you are working in casual wards. It's so common because Sri Lanka have an aging population and the prostatic problems are increasing. First, I want to introduce a few terminology that we use. Lakshmi, lower urinary tract symptoms. Do you know what is lower urinary tract? It is bladder, prostate, and urethra. You have to know that LUTS is not just a prostate specific. It's not an organ specific. It can be a bladder issue, urethra issue. So it's not an organ specific. And LUTS can be, you can see in females as well. So it's not a gender specific. Bladder outflow obstruction mean can be due to so many other reasons like urethral stricture, neurogenic bladder, obstructed stone in the urethra. So so the prostatic obstruction is a one cause of bladder outflow obstruction. Then when you do a digital rectal examination, the prostate feels like you are demamming. That's a benign prostate. When you feel with the knuckles, it's a hard, malignant prostate. So with the finger, when you examine, so never say BPH. BPH is a histological diagnosis. You have to see under the microscope, either a biopsy specimen or QRP tips. So BPE, you have to say benign prostatic enlargement, the DR. Then not everyone with benign prostatic enlargement will have blood outflow obstruction, like graying of your hair those prostate is enlarged, no need to see a clinician. But some enlarged prostate will cause blood outflow obstruction. Then we will say a benign prostatic obstruction. So these words are different. BOO, BPE, BPO, and BPH. There are so many causes of bloods. I have told you BPH is a one cause, but UTI, bladder cancer, bladder stones, and a lot of other causes for the bloods. If you want, I can share the presentation so you can read it. Now, why we are worried about urine retention? It can be acute retention, or it may be acute and chronic, or maybe a chronic retention. Why we are worried about it? When the prostate enlarge in size, it's blocked the prostatic urethra. So initially they will have LUDs. If you're not treating well or patient is not coming, then gradually, because of the incomplete emptying of bladder, gradually urine accumulates, and one point they can develop acute retention. Because of the retention, they can develop chronic retention, chronic stasis of urine, they can develop infection, they can develop stone. But the most worrying problem is the urine stasis or swelling of the kidneys, the long run, hydronephrosis, and hydroureter that can result in obstructive uropathy. That's a worrying major complication of blood outflow obstruction. So this pathological drawing indicates whenever they have a blood outflow obstruction, you will have trabeculated bladder, thickened bladder. If they have a high pressure inside the bladder, then the urine goes back and dilate the ureter and obstruct the kidney and cause thinning of the cortex. That's known as hydronephrosis, hydroureter. But you have to remember, not everyone with acute retention will have this kind of features. This specific condition is known as high pressure chronic retention. I am introducing the term high pressure chronic retention, HPCR. In HPCR, there's a lot of pressure inside the bladder, the urine goes back. When the patient comes to your ward or casualty ward, he will have high serum creatinine. And when you do imaging with ultrasound scan, they will have hydronephrosis. So you have to remember, in this kind of patient, you put catheter, but remove the catheter. If you remove the catheter, it will develop the retention again, the back pressure again, renal impairment will happen again. So when you put a catheter, their symptoms will improve, serum creatinine will improve, and the hydronephrohydration will improve. So never do a trial without catheter in a patient with high pressure chronic retention. As I told earlier, not everyone with blood outflow obstruction or retention will have high pressure chronic retention. Maybe 1 in 10 will have this problem. And never label them as a CKD, because the admission may be 300, 400. But once you put a catheter, creatinine will improve. So never label any patient with acute retention as CKD, because it can be improved. So high pressure chronic retention, there's no role for trial without catheter. We have to go for a surgery, that is a TURP, transurethral resection of prostate. You have to remember, not in everyone with acute retention. I will come to the protocol management of acute retention till why, but I am just introducing the one important emergency or important condition. It's a subtopic on the acute retention. This is high pressure chronic retention. Now we all know the management of blood outflow obstruction due to BPH. About 30 years back, everyone we had to do a TURP, but now we have a good medication that is tamsulosin. It relaxes the prostate. But you have to remember, tamsulosin needs 48 hours to act. This is so tactic. So if you give it, it will start working within days. Two side effects you have to tell the patient. One is postural hypotension, so they will have a giddiness in the morning, and retrograde ejaculation. Young people, if you are giving 55, 50, sexually active, you have to tell them that the sperms, semen will go back into the bladder, retrograde ejaculation. Now, so tamsulosin is one of the good medication, and other one is shrink the prostate. We give 5-alpha reductase with the finasteride. You have to remember, to get the benefit of finasteride, it will take up at least about 6 months. So this will relax the prostate, act quickly, and finasteride will shrink the prostate, takes time because it acts in the nuclear receptor inside the cell. Now, you can't use the finasteride in a small prostate, less than 30 gram prostate. No point of giving finasteride because you can't shrink it further. The prostate size is more than 30 gram, then we can the finasteride and shrink the prostate further. Give both together, the benefit will be better. But it's better to start with tamsulosin, and symptoms are not improving, then you can give this one. So for a blood outflow obstruction, we have two options: medical management and surgical management. Even though this topic is emergency, I am introducing the core knowledge, then only you will understand the emergency management. So when the patient comes with the acute tension, you may have seen so many times, they will have a very severe low abdominal pain, not empty the bladder for maybe so many hours. So they want to empty the bladder, but they can't empty the bladder. Most of the time, the amount of urine will be less than 1 liter. Always record the amount of urine you drain after catheterization, because that's important in decision making. If someone you put a catheter, about you are getting 2 liters of urine immediately. Then the urologists know this bladder must be like a tissue paper, and contractility will be less. So even if you remove the obstruction at the bladder outflow level, success may be questionable. So we have to tell that before the surgery to the patients. So always, once you put a catheter, document amount of urine that comes immediately, the BHT, because that is important in the subsequent management by the specialists. So I'm just touching only the acute retention today, where you will get usually around 700, less than 700 ml of urine, and once you put the catheter, a patient get a great relief. But I told you there's a subset known as high pressure chronic retention. But any acute retention, at least you have to do a serum creatinine, the ultrasound scan to see the upper tract, the prostate and bladder. And so when you do that, in a high pressure chronic retention, they will have upper tract dilatation in the scan, and they will have a high serum creatinine. Now I have to tell one more thing. There are subset of patients, when you put a catheter, they develop 2 complications, especially the high pressure chronic retention people. One is diuresis. Once you put a catheter, they produce large amount of urine, more than 200 ml per hour continuously. That's people can die because of that. Into the urine output. Once you put a catheter, hours, more than 2 hours, passing more than 200 ml of urine per hour, then you have diagnosed this post-operative diuresis. Then start IV fluids and closely monitor the urine output, because they can develop low blood pressure, they can collapse. So you have to remember. So don't just put catheter and discharge all the patients same day. At least monitor 24 hours. We have seen this diuresis and patient are getting admitted to the ICU because of CVA because of hypertension. So monitor the urine output. That's one complication subset of patient will develop after catheterization. Other one is post-obstructive the hematuria, decompressed hematuria. When you put a catheter, the bladder suddenly get collapsed and they develop severe hematuria. A lot of UK doctors ask me whether we have to gradually decompress the bladder. Of course, that is research-wise, there are no evidence, and you can't do that because if you know the physiology of bladder pressure changes and the amount of urine, you know that it's very difficult to reduce bladder pressure complication. Of course, if they are going to develop, then you have to manage. So two complications, remember, post-obstructive diuresis and decompression can happen. What do you know in the management? Do a DRE. How do you know this is a bladder? When you examine, it will be like a 20 weeks gravid uterus. You know the gravid uterus will be at the pubic symphysis at the 12 weeks, at the umbilicus at the 20 weeks, at the sigmoid sternum at the 36 weeks. So if and the consistency will be like a rubber ball. So if a male is coming with 20 weeks gravid uterus, that's a bladder. It never go above the umbilicus. You know the basic anatomy, urachus attached to the umbilicus, right? So that's a classical thing. And then you put a catheter, record the brain amount of urine, serum creatinine, ultrasound scan. You do a DRE. If you think it's a malignant, like your knuckle, then you have the PSA. Better to delay the PSA for 2 weeks because catheterization will increase the PSA and retention itself will increase the PSA. But in our specialist management, if you think it's a hard prostate, and I straight away do it because most of the time our patients come with late diagnosis for prostate cancer with bone mets. So PSA will be more than 100. But you know, traditional teaching is do it after 2 weeks. Now, okay, you will ask a question now. Yes, patient came to the retention. We have put the catheter. Now, what to do next? So you check the renal function, serum creatinine. Is it normal? Yes, most of the time it's normal. Good. What about the prostate? Feel benign? Yes, that's good news. Okay. How much of urine came out when you put the catheter? Less than 1 liter? Yes, that's a good thing. Rather, more than 1 liter is not a good sign. Less than 1 liter is a good sign. Okay. Good. Then what you do? You start him on alpha blocker, that is tamsulosin, and discharge him and ask him to come after 48 hours. Okay, I told you that it takes about 2 days. Now, in Sri Lankan setup, we usually ask them to come, maybe after 1 week. Because it's not nice you discharge today and ask him to admit, after 2 days. But the problem is, more you keep the catheter, more infection and more catheter-related problems. But more you keep the catheter, more success of trial without catheter, right? So trial without catheter is successful. Then you have to continue the tamsulosin. Now you have to remember, don't just discharge the tamsulosin. Ask him to come again in a 2 weeks time and do a serum creatinine and do a follow-up ultrasound scan and check that everything is fine. Because some people will have residual urine will be high and serum creatinine will be abnormal. So you have to do that. Suppose now if you think he's having some UTI as well, in addition to the retention, you can give some antibiotic. If you think they have a constipation, in addition to the alpha blocker, you can give Laxative. Now I'm coming again. So this is a green pathway. Green pathway. About 50% of the patient will go in this pathway. That's a normal thing. So suppose now renal function is abnormal, and that's the condition I have told you. High pressure. If that's abnormal, you put a catheter. There's no place for a trial without catheter. Okay, you have to go for a TURP. If the patient is fit. If the patient is not fit even for a haircut, then there's no point of preparing him for a surgery. Then we have to keep him in a long-term catheter. Now, when you put the long-term catheter, better to put a silicone catheter because 100% silicone catheter you can keep for 3 months. Our normal rubber catheter or latex catheter, we can keep only for 1 month. And I'm not happy with the lot of products problems, difficult to deflate 100% silicone catheter. Not keen on a urethral catheter, you can keep on long-term suprapubic catheter because some people are not in our country, but in other country they are, they are keen on sex, sexual life even after retention. So they want to get rid of urethral catheter. So we keep on long-term suprapubic catheter. So, but common thing when we do is we do a TURP. That's if renal function is abnormal. Suppose you feel renal function is normal, but prostate feel malignant. Then it's a malignant pathway. That's a separate topic. Prostate cancer, the commonest cancer in the male worldwide, and it's underreported in Sri Lanka. I think in Sri Lanka also it's one of the commonest cancer. No one is doing a proper study or survey. It's the commonest cancer in the male worldwide, the prostate cancer. Like breast cancer is the commonest cancer in the female, right? So that's a different topic. We have to go in a prostate cancer pathway. Suppose the amount of urine comes more than 1 liter, suppose 2 liters, 3 liters. Then you put a catheter, but you have to tell the patient, look, you can do the TURP, but the success may be 50-50. Or else he can be on a long-term catheter or clean self-injected catheter. Okay? That's the other one. Suppose trial without catheter failed, then of course he's fit. He'll go for a TURP path. That's a very important slide because I have seen the most of the doctors are not clear about how to manage the active retention. If you know this, that's more than enough. Okay, that's an important slide. So there are a few more things about the catheter. This latest catheters, currently the product is not good in Sri Lanka. A lot of complications we have reported. Now, when you are using, it's a two-way catheter. One way for it to come out, other way for a inflate the balloon. The green one is 14, size 14, and the amber color, the orange one is 16, and red color is 18. You can remember, when you go in a signal light, you go in a green when you stop for amber color, and then we get a red. So 14 French, 16 French, and 18 French. So 3 French is roughly 1 millimeter. So 18 French mean the inner diameter of the, outer diameter of the catheter will be roughly about 6 millimeters. Again, I want to say one thing: use smallest catheters as possible. People think use the big catheter. More bigger the catheter, they compress the urethra. You know that urethra have lots of glands. They will be blocked, and they develop abscesses and strictures. So always use small catheter as possible, 14 as possible. And sometimes I have seen people put catheter and they develop periurethral pericatheter leak, they increase the catheter size. That won't work. So actually, what you have to do is, if you have to give a small amount of sterile water in the balloon. 10 cc is enough. More you put, bladder will think, okay, there's a foreign body in the bladder. Now I want to push it. So when you put a catheter and a catheter balloon, bladder won't push the catheter out. It thinks as a foreign body. So they develop severe pain and also they develop pericatheter leak. So increasing the size of the catheter is not the answer. You reduce the balloon size, and also sometimes what I do is, if a patient is going to be on long-term catheter, I relax the bladder by giving anticholinergic, such as oxybutynin, sulfenacin, and things. Right? So you know about the catheter, the balloon will be here. And I'm not going into the details of other common problem you get is difficult to deflate the balloon. Yeah. Ideally, if you have a periphery, if you have someone ultrasound scan, the better thing is ultrasound guided suprapubic needle puncture. Don't put ether and things, because once the ether comes out, it irritates the bladder, cause sort of pain and fibrosis. But other methods to deflate the balloon, of course, you're seeing teach you. So you know the two-way catheters, and also we have three-way catheters. I will come to that. Whenever a patient have a gross hematuria and you want to wash the bladder, then we have to use the three-way catheter. One way urine will come out. This catheter and see, the one lumen is for a urine to come out, other tiny lumen for a balloon to inflate the balloon. The three-way catheter, this is the main urine lumen, other one is for a balloon, other one is for a irrigation fluid. This is the catheter I told you, the silicone catheter. They're expensive. Maybe now, before the economic crisis it was for 2,000 rupees, maybe now expensive. But the good thing is they don't cause a lot of fibrosis reaction. So, and you can keep for a 3 months duration. So that's silicone catheter. And especially in difficult catheterization, but the other latest catheter is flexible. So sometimes difficult catheterization, it's difficult, right? So catheterization, of course, I'm not going to relax the patient's sphincters and put lots of 20 centimeter long. You have to anesthetize all urethra. Never put a lignocaine to the catheter and put the catheter. We are not going to anesthetize the catheter. We have to anesthetize the urethra, you remember. And never let an attendant to put the catheter. You have to remember it's a sterile procedure. It will damage the urethra, lifelong misery, urethral stricture. If you introduce the hospital infection, the ESBL, external spectrum beta-lactamase releasing bacteria, disaster. So please, always think your patients like your parents. So never let the attendants do the catheter. You have to do it. Sterile procedure. Put gloves. And I said the male urethra is 20 centimeter. So at least 20 milliliter of lignocaine gel. I know lignocaine gel is not available freely in the hospital, but you ask the patient to get it from the outside and put it. So male 20 ml of plain lignocaine gel. Female urethra is 5 centimeter, 5 ml of lignocaine gel, and you wait for 5 minutes. So more gel you put, more you relax the patient, catheterization becomes easy. You just touch the gel in the catheter and put it won't work. It will damage the urethra, especially at the bulbar urethra. Talk with the patient, more gel, and a good catheter like silicone, then your life become easy, right? Then you can become expert, right? It's a very basic procedure. All the doctors should know. So, what are the things you have to prepare? So, it's undergraduate teaching. Yeah. So, do it like a professional. Catheterization and do it properly. We are seeing rising amount of ESBL infections, and we don't have a good antibiotic to cover. So please, always sterile procedure. Prepare your table, gloves, and gauze, and catheter bag, gel, and the sterile water to inflate the balloon. Then you proceed. Enjoy and do it, right? And I told you, lots of gel, and that's the whole urethra. And penis is a S shape, so always keep when you straighten this the penis up, one curve will be disappear. Other curve, of course, very difficult because pubic bone is there. So then it's become L shape. So the bulbar urethra, you are very careful. Don't push it hard. Then you make a urethral stricture. One of the common reason we see for the urethral stricture is doctors. So learn it properly. Don't damage the urethra. And we have seen a lot of other issue is when you put a catheter, please put the catheter up to the Y junction, right? Because then you wait until the urine come out. Never ever inflate the catheter balloon without seeing the urine, because if you fill the balloon in the urethra, disaster, damage, bleeding. So if you're not seeing the urine, common cause is maybe gel is blocking. So you can just press the abdomen and see, still not coming. You can put a syringe here and aspirate and see. Most of the time it comes. Still not coming, then you can flush some saline into the tube and see. So, but never ever inflate the catheter balloon without seeing the urine. The other thing I want to say is, when you put a catheter, please put the prepuce back in the normal position. Otherwise, they develop paraffin. Like I've seen so many times in medical wards and surgical wards, the doctors, they put the catheter, they forget to put the prepuce back. So please, the common cause of paraphimosis is doctors. We make a lot of problems. So we have to improve our skills. You see, when you put a catheter forcefully, patient is not relaxed well, it goes somewhere else. And you go in that hole and dig more, it goes a false passage. Then, later when it's healed, it goes urethral stricture. Urethral stricture disease is a disaster. Lifelong, they are going to come with a problem. So, careful. Urethral stricture disease. It's common at the bulbar urethral region. You can see a patient having this ascending urethrogram, the anterior urethra, this is a bulbar urethra stricture, known as ascending urethrogram. But the contrast is going into the bladder. This is a prostatic urethra. You can see the veru here. Contrast is going, but it's a very bad stricture here. Ascending urethrogram. So one of the investigation helpful in diagnosing of stricture. Now you will ask the question, okay, doctor, now urethral catheter failed, what we can do? Then, if you have a specialist, or you can ask them. One thing is, if you have a accessible, flexible cystoscope, we can put a scope under direct vision. Over that, we can put a wire, guide wire. Over that, we can put a catheter. Suppose, it's midnight, 2 a.m. you're the house officer. Now what you can do is, you can put a needle here, needle puncture, and remove the urine. Patient will be all right. Then in the morning, with the more senior support, you can deal it, right? So that is suprapubic needle aspiration. But daytime, if this is failed, you are on periphery, and you cannot get the senior house officers registered, they can do a suprapubic catheter. Again, suprapubic catheter, very careful. If the abdomen is a virgin abdomen, it's an easy procedure because distended abdomen, distended bladder, aspirate and see, urine is coming, then you can put a suprapubic catheter. Under local anesthesia, now we have suprapubic catheter sets. It's available in a ward. Give a local and you can do it. But you will have to at least learn once and do it, please. Because the virgin abdomen is easy, but if there's laparotomy or something, then the bubble loops may be here. And I have seen few times suprapubic catheter into the bubble. So, but if you have ultrasound scan, then it's good. You do ultrasound scan, you see the bladder nicely, put a needle, and then you can put a suprapubic catheter. So learn suprapubic catheter is an easy procedure. All doctors should know. And there is a suprapubic catheter puncture set. Yeah, that's available. Okay, so one of the common condition, I have spent lots of time in acute retention because very common and important, a lot of issues in management. Paraphimosis, I have told you. What happens is sometimes people put catheter, and the same thing happened to this patient. You can see they put the prefuse back and forgot to put it back. So there is a big swelling of prefuse. And if you leave this, because that acts as a band, like a rubber band in a coronal sulcus, then there will be a massive swelling of the gland screen. We see people, some boys, marry, and they never did the masturbation before. In the first night, what happens is prefuse goes back, and rubber band effect, gland screen starts swelling, and they are anxious to come to show the doctor. So they come sometime after 3-4 days. During that time, sometime gangrenous gland screen. So you have to know this condition. Someone's coming and complaining, pain in the penis, examine the penis. And as a doctors, we can prevent this happening in the hospital by putting the prefuse back after catheterization. Now, what to do if this comes? Very easy. So now this is a normal prefuse. It comes back and causes a rubber band effect. That's a phimosis. If it is a tiny one not coming back, it's a phimosis. Phimosis, paraphimosis. So what you can do as a uni doctors are put some gel into the gland penis and this area, and if you push like this, push the gland in, pull the prefuse out. If you do this, most of the time you will be successful if you do it early. More delay, more difficult because it becomes more and more like a apple is become very big. It is difficult. If that is failed, then what you can do is take a tiny needle like 26 French or insulin needle and put multiple puncture because it will be like a swollen prefuse, lots of water inside, about 10-20 puncture. Then you press the prefuse, all this water sprayed out, comes out. Then you can do the same thing again. You will be successful. That's a dandy procedure. Now still you are failed and it's not coming, then of course you have to take to theater, give a local anesthesia and do it properly. Sometimes we had to put a small cut, dorsal split at the prefuse. So that's a paraphimosis. The next one, the famous one, it's acute scrotum. If you are working as a urologist in UK or Australia, this is a condition, disturbed sleep, as a urologist every night. Because in Sri Lanka, we are happy because these acute scrotums are dealt by general surgeons. And everyone know how to manage this. But other countries, it's a urologist managing it. In the midnight, someone coming with a sudden or severe pain, then the issue. Because if you miss a testis, the NHS trust have to pay millions. So that's a legal issue. So if a classical age group, like around the puberty, boys are coming with severe pain, can be a acute scrotum, because boys around 14, teenage, the size of the testis increase, and the cremasteric muscles are more reactive. So even a tiny trauma or someone touching or hitting, then there will be a rotation of testes. Of course, some people with the bell clapper deformities like horizontal testes have more chance to develop acute scrotum. So whatever the acute scrotum, it can be a torsion of the testis, can be a torsion of the appendix of the testis. Sometimes you have a small appendix here. Of course, that's not a major issue. Other one can be a internal scrotal hernia that is obstructed, or maybe a epididymoitis. Sometimes very difficult to differentiate clinically. If you think it's a classical presentation, no dysuria, if you think it's acute scrotum, don't wait for an ultrasound scan. Straight away, take to the theater, explore it. If it's negative, that's fine. And if rotated, if it's torsion, if derotated, color comes normal. Then fix with the 3-point fixation both sides. Because why both sides? Congenital anomalies are bilateral. If someone develops torsion in this side, he has 40% chance he will develop torsion on the other side. So always fix the other side as well. So bilateral of defects. Now, testis color is not coming back to normal. It's a dead testis. Then you have to do occlude the testis. So more time you delay, more death. Right? So better to do it within 6 hours. But you can salvage the testis up to 24 hours. Right? So the live testis or dead testis, it's time is the issue. So do it within 24 hours. So more you delay, right? Sorry for the interruption. So I have joined with the presentation, right? So, okay, so we were discussing about acute scrotum. Now the next thing I want to talk about the urosepsis. So we discussed about acute scrotum. Okay, so no scan, because ultrasound scan is not going to diagnose acute scrotum, and it's not going to exclude the torsion of the testis. So ultrasounds have no place in the management of suspected torsion, suspected testicular torsion exploration. Okay. Now the next one is urosepsis. Remember, but any sepsis, you have to do 6 things. Give 3 and take 3. Give 3 is oxygen, broad spectrum antibiotic, and enough IV fluids. Take 3, take appropriate culture. If you think it's a urine problem, urine culture. If you think blood tissue, blood culture. If you think meningitis, lumbar puncture culture. So relevant culture, and always do arterial blood gas analysis and check the lactate, because serum lactate predict the prognosis of sepsis. More than 2 indicate there is a reduced perfusion of the organs. More than 4, more high chance of mortality due to sepsis. So measure the ABG and lactate, then measure the urine output. Maintain it at least 1 ml per kg per hour. So in sepsis management, 6 important things. Give 3, take 3. You have to do this within first hour. It's known as 1 hour bundle. 1 hour bundle. Surviving sepsis campaign. 1 hour bundle. Do it this. Then you have to find the source and control the source. Can be kidney, can be abscess. Do it within 6 hours. So sepsis 6. Now, why I am talking about urosepsis? Urosepsis can kill the patient within hours because the E. coli is a common organism, the gram-negative bacteria, release the endotoxin. The gram-negative sepsis is very bad. It can kill the patient within hours. So you have to recognize the patient. If you recognize early and good broad-spectrum antibiotic and fluid, they will improve dramatically. So urosepsis, here you can see of a kidney. Yeah. Can you see me again?
Yes, sir.
Okay, so many interruptions, right? Anyway, so so in this kind of obstructed kidney with infection, we use a term obstructed infected kidney. The obstructed infected kidney, other than sepsis 6, we have to unblock the kidney. To unblock the kidney, there are 2 ways. Either you can put a stent, or you can put a percutaneous nephrostomy. This needs anesthesia. If patient is fit, this is good. Patient is not fit, hemodynamic unstable, under local anesthesia, we can put a percutaneous nephrostomy, PCN. Good thing about this is local anesthesia, but it's a discomfort of the patient, back outside. In our setup, very difficult to maintain. Other problem, we are putting a hole in the kidney, can cause hematuria, especially in septic patient. The coagulopathy is there, then this is not feasible. Then we have to go for a JJ study. So to unblock the kidney, we have 2 options: either stenting or PCN. Then later we manage the stone. So never ever worry about the stone management when the patient have an obstructed infected kidney. Okay, unblock the kidney, get the patient better. After a few weeks, then you can go and break the stone. There are so many options available. Depending on the stone location, we will decide what to do. Never ever manage the stone when the patient have a obstructed infected kidney. If you do it, patient will die. Okay. Then other common thing we do in the wards are transrectal biopsy of the prostate, suspected prostate cancer. Again, I say this is not a transrectal, it's a transfecal biopsy. We are going through putting the needle through the feces and touching the feces and putting the feces into the prostate. Because of that, we are now going away from the trus biopsy. In the future, we are going to do the transperineal biopsies. But of course, in Sri Lankan setup, we are not starting that because of we need a good ultrasound probes and things. So if you do this, patient complains shivering, that means he's going to develop sepsis. So give good antibiotic prophylaxis before the procedure and monitor the patient very well. So urosepsis can happen after biopsy. And if you go a bit deeper, you damage the urethra, they can have a hematuria. Rectum can bleed, they can have a PR bleeding. Lots of biopsy, swelling of the prostate can cause acute urinary retention. So remember the complications of trus biopsy: sepsis, retention of urine, hematuria, rectal bleeding. But after biopsy, shivering, then it's the sepsis. Give a good antibiotic. We love to give gentamicin. It's about 100 rupees. I don't know how much now. 1 vial is very cheap and very good antibiotic, gentamicin or amikacin or something. That's very effective against the E. coli. So the next thing is sometimes you get a patient passing a lot of bloods in the urine, visible hematuria, and develop retention because of the clot. How to manage that? The three-way catheter, then you can put saline and forcefully with the bladder syringe, if you push the saline, pull the saline back, the clots can come. Again, it should be a fresh clots, very old clots, formed clots, very difficult to remove. So clot retention, you have to put three-way catheter, and you can do a bladder washout. Okay, here you can see a three-way catheter and the bladder syringe. You should have at least one syringe, always the boards, a bladder syringe. You can put saline in 100 ml, get the 100 out, put 100 in, 100 out. You do this procedure until the output urine is clear. Clot retention. How to evacuate the clots is very important. Okay. If you leave it more time, clot become foam clot, very difficult to remove it. Sometimes it's a challenging condition for a urologist. So always prepare the things. 2 kidney trays. In one you put a lot of saline. This is a bladder syringe. Take the saline, give inside, take it out, and put the spoiled saline here. Put it, get it again in, out, in, out, in, out until the urine is clear. Then you start irrigation. Again, you have to tell the staffs properly maintain the irrigation. If you stop in the middle, midnight, then they develop retention again. So clot retention, as duty doctor, you should do it. Don't transfer the patient for a tertiary center. During that time, clots is formed and more problems. So continuous irrigation, you have to do it after the clot evacuation. The last thing I want to talk about is the Fournier's gangrene. It's a necrotizing fasciitis. You have seen the legs, but this is in the scrotum. Usually multiple organisms are involved, gram positive, gram negative, and if you leave it, they will die within days. Important. So, how do you know it's a Fournier's gangrene? It's sometimes you see necrosis, sometimes you won't see the necrosis, where they come with the redness, but when you feel it, they will have more pain when compared to what you see. And sometimes you will see crepitation. Suspect Fournier's gangrene. An important thing is good antibiotic, ICU care, and cut and remove all the necrotic tissue. Don't worry about how much you are cutting. You have to cut and remove all the dead tissue until you see the bleeding tissue. Good wound management, necrotic management will save the patient. Right? So here you can see removing everything of dead tissue. Now patient is improving. Most of the time, testis will be viable because the blood supply of the testis is coming from the abdominal aorta at the L2 level. So they are viable. So recognizing urological emergencies, very important, like retention, high pressure chronic retention, paraphimosis, clot retention, urosepsis, acute scrotum. There are more things like penile fracture, paraplegia, but your level I am not, don't need to know those advanced things. Thank you very much. Sorry for the multiple interruptions because of the lightning here in Jaffna. If you have any questions, I can answer. You can send a question through the CV or my email. And I am happy to share the slides so you read it. And good luck. Anyone have a question? Anyone want to ask? I'm happy to discuss.
Thank you for your excellent lecture, sir. So there are a few questions in the chat.
Okay. Yeah.
First question. Sir, can avoiding the urge to urinate for longer period can exert effects similar to acute urinary retention?
Okay, so sometimes we have seen precipitated urine retention. People go for the bar and drink a lot of beer. So they think they can go home and empty the bladder. And the beer itself, alcohol, reduces your bladder sensation. So when you stretch the bladder a lot, you are studying the physiology, the muscles, when you stretch a lot, they lose their contracting ability. So then they develop retention. Same thing will happen. Sometimes you send the patient for a scan, the scan room, big waiting list, they hold the bladder with full bladder for hours, then they develop retention. I have seen a patient going in a motorway, and he couldn't get he want to empty the bladder, but there's no exit. So he was holding until go home and develop retention. So more you stretch the bladder, you will develop retention. That is known as a kind of precipitated retention. I hope I have answered the question. Anything else, Tanashi?
Yes, sir. There's another question. In adults, what are the cutoff values for renal pelvis anteroposterior diameter for mild to moderate hydronephrosis?
Okay, so this is more technical questions. I think the radiologist should answer. But mild, moderate, severe, it change between people. But it's a age cutoff is depending. Pediatric and adults is different. I'm not sure about the cutoffs. But by the look of the ultrasound images, I will see the cortical the meat size, then we decide. Okay, very thin the out cortex, then it's a gross hydronephrosis. So you see the thallitis and renal pelvis, and if the moderate thinning of cortex is a moderate hydronephrosis. Just only the pelvic systems are dilated, there is a mild, but I'm not exactly sure the numbers. The radiologists know better. Yes.
The next question is, sir, if acute retention urine, put the catheter, observe 24 hours and start tamsulosin and discharge and ask to come in at 48 hours. Check the serum creatinine normal. Has to continue tamsulosin for how long?
Okay. Again, you have to remember for hypertension patient, if you start amlodipine, losartan, it will be lifelong because you are relaxing the blood vessel to reduce the pressure. In a prostate, we are relaxing the smooth muscles in the prostate and the bladder neck and prostatic urethra. If you give, tamsulosin will work. If you stop, won't work. So like a hypertension, you give alpha blocker. Here you have to give the alpha blocker lifelong. Of course, patient will ask this question, whether I have taken. Yeah, you are taking for hypertension, you are taking for diabetic. Take it. If you don't like tablets, then you go for a surgery. So that's a answer for your question. Yes, next one.
How long we have to keep urinary catheter in a patient with long-standing LUTS?
Long-standing LUTS, we won't put catheter. LUTS is a low urinary tract symptom. We put catheter only for acute urinary retention. LUTS we will manage medically, tamsulosin, plus or minus finasteride. If medical management failed, we go for a surgery. So what are the indications for surgery? If someone have complicated blood outflow obstruction. What is complicated blood outflow obstruction? If the patient have complications of blood outflow obstruction. What are the complications of blood outflow obstruction? I told you the start, recurrent acute urinary retention, obstructive uropathy, recurrent infection, urine infection because of the urine stasis, and the bladder stone. If someone have a complicated benign prostatic obstruction, no point of giving medical management. We go for a surgical management. Another relative indication is patient on medical management, severe LUTS, medically is not improving, then go for a surgery. So LUTS management either medical or surgical. Acute retention only we put catheter. How long catheter? Of course, I told you after 48 hours or 1 week, you remove and see. If talk fail, what to do? You have to go for a surgery. If patient not fit for surgery, what? Long-term catheter. Long-term with how long? What I do is, okay, every 3 months, he's in silicone catheter, I remove and see whether he's passing. Sometimes people get success. So how long? Till he passes the urine. Most of the time, bed-bound patients and fragile patients, we keep for ever. Yeah, I hope I have answered the question.
So there are two more questions regarding antibiotics. One is, should we give broad spectrum antibiotics for Fournier gangrene? Is it compulsory to give antibiotics? And the other one is, should we start antibiotics in all patients who underwent catheterization for acute urine retention, even if CRP and UFR doesn't show evidence of infection?
Yeah. So acute, second question I will answer first. Catheterization is a sterile procedure. It has no features of infection, no need of antibiotic. It's a clean procedure. Okay. But if you think there is associated infection, then only you have to give the antibiotic. That's answer to the second question. The first question, do we have to give antibiotic? Definitely in Fournier's gangrene, we have to give antibiotic. What antibiotic? We have to cover the gram positive, negative, and anaerobes. We start broad spectrum antibiotic like meropenem. So meropenem will cover everything. So we have to definitely give broad spectrum antibiotic early as possible. Some people, if you're not having a meropenem, then we give third generation cephalosporin like ceftriaxone plus aminoglycoside plus metronidazole. So you can give like that kind of schedule, or the advanced imipenems, but all based on your hospital protocol, and your microbiologists will have a protocol. So in an exam point of view, when you go abroad, always you have to follow the hospital protocol. They will have a management plan for urine infections. Yes.
There's another question, sir. Please describe catheter care, flip flow also.
Okay. Catheter care, again, in Sri Lanka, the catheters are poorly managed. And I don't like patient, holding the catheter bags and, going here and there. So one thing is put a good quality catheter like silicone. Then I put a leg bag. That is not available in the government sector, but is available in the private sector. The leg catheter bag. That means they can anchor the bag to the thigh. There are thigh bag and the leg bag. So you won't see the bag outside. They put a trouser and they walk like normal people. So that is a catheter bag, leg bag. Other thing is I put a tap, as you said, the flip flow tap. So tap is again, it's not available in the government sector. So what I do is, if you see your Eurometer, there's a tap, or some catheter bags have that tap. So I remove the tap from that bag, and I put that tap into the catheter. So whenever the patient gets urged to pass, he can press that tap and put the urine into the toilet, and then can close it. So there's no bag at all. He can roll the catheter and put it inside the underwear. So he will feel like a normal people. So just a catheter and a tap, no bag. If you're putting a bag, leg bag. And regularly change it. The other problem we see is a repeated catheter block because of our the hot environment. So what I ask them to do is, most of the time is a calcium phosphate sediments block the catheter. So then ask them to drink more water. The urine color should be the water color. The urine color should be the water color. So 4 liters, and ask them to get some lemon juice. A lemon will dissolve these sediments. There are some commercial preparation as well. So yeah, so and if repeatedly getting blocking, better, silicone catheter is better, and maybe a large diameter catheter to remove the sediments. That's a challenging part of long-term catheter. I agree.
There's one more question, sir.
Yeah.
Shall we continue with that, or shall I ask participant to email that questions?
Maybe that's the last question we will answer, and then yeah.
Regarding the catheters, what are the commercial preparations for catheter blocks? And also, how frequently should change the catheter bag when patient on silicone catheter?
Yeah, so catheter bag, of course, some people, some patient maintain well, If it is coming, ugly color, you have to change it. There's no fast and hard and fast rule for catheter bag change. Catheter change, of course, I said earlier at the start, latex catheter 1 month, silicone catheter 3 months. But in Sri Lankan setup, 3 months it won't last. It can block. So I changed in 2.5 months. These 3 months are for the developed countries. So catheter bag, there's no hard and fast. If you think it's not expensive, catheter bag, it's about 200, 300 rupees. But catheter is an expensive one. So and you asked how to prevent catheter block. Any commercial preparation. There are so many preparations in the market, but they are not scientifically proven to be effective. All those are just marketing strategies, but I never believe they are not recommended. But as I said earlier, just give a lot of water and the lemon juice. Yes.
So if you have very specific further questions about the lecture, you can email us on office313@gmail.com. And in the absence of further questions, let's conclude today's program. And Dr. B. Balagobi, sir, thank you very much for your excellent lecture and your precious time. Finally, then you have to please give us the feedback and find the link in the chat box and answer the post-assessment questions, and then you can receive your e-certificate. Thank you, everybody, for participation. Thank you, sir.
Thank you.